It's like transporting the baby from one hospital to another hospital. Maybe the baby is so sick and they have to go to like from here to New York to have a special surgery done. How would you transport them? They have respiratory therapists that just do transport. You know, they make a lot of money. They make like $40 an hour. You know, but you gotta fly all the time, or maybe riding the ambulance all the time. All right, so let's look at it. So now there is something called regionalization, and what happens is that the equipment to take care of babies sometimes is very expensive. It costs like thousands of dollars. And then the nurses that work in the NICU make a lot of money, respiratory therapists, transport. And you don't really have that many sick babies. You know, in a given month, maybe one or two that will be really, really sick. But now you've bought all this equipment, you have all these nurses trained that are just gonna sit around waiting until a sick baby will show up. So, there is no need for all the hospitals in an area to buy every equipment that is needed to take care of a sick baby, because they'll be wasting money, you know. They're training people to do it, they'll be wasting money. So that's how they came up with regionalization. So in a given region, let's say in Albuquerque, there will be one hospital, just one hospital, that will have all the equipment that is needed to take care of the baby, no matter what is wrong with the baby. So instead of Presbyterian buying all the equipment and spending all this money, UNM, you know, has it, Loveless has it, but now you get one baby a month, it's not really worth it. So what they do is they appoint a hospital in a specific region as a hospital that will be a level 3 NICU, okay, that can take care of whatever that is wrong with the baby, so that if a baby is born at Pres and they're very sick, they can be transported to UNM to have that surgery or whatever done. If a baby is born at Loveless and they're very sick, they need special surgery, they come to UNM. Okay, so that reduces cost. Okay, so that's what regionalization is all about. Okay, one hospital in a geographical region provides any type of care a neonate might need. The hospital provides education and support for the other hospitals in the region. So the hospital can train, let's say, one person at Loveless to take care of a sick baby that has been born until the baby can come over. They do the same thing for Pres. They may do the same thing for grants, you know, something like that. They give them education, they update them on what is needed to be done, okay, as far as the different diseases are concerned that the baby may have, okay. All right, so that's regionalization. So based on that, we have level 1, level 2, or level 3 NICU. So the levels of the NICU, the level of NICU is classified based on what that NICU can do, okay? So a level 3 NICU will be a NICU that should be able to do everything that the baby might need. Okay? Like UNA should be a level 3 NICU. Okay? I think Presbyterian is level 2. Okay? All right, so here's everything that a level 1 NICU can do. Care of uncomplicated maternal and neonatal cases. Competency emergency care for unanticipated obstetric or neonatal complications. early identification of high-risk maternal or neonatal patients, provision of social services and other preventive assistance, especially to mothers. So level 1 NICU can do that. Now you take a hospital like Grants, that will probably be a level 1 NICU. Okay, they don't really do much over there. Level 2 NICU, okay, they can do everything that level 1 NICU can do. Plus perform C-section quickly. Rapid sequence. Okay, mother comes in and they have to be able to set it up right away and do a C-section. Provide mechanical ventilation up to 24 hours at least. The baby is very sick, needing mechanical ventilation. They can at least have somebody there to take care of the baby at least for 24 hours before the baby can be shipped somewhere else. They have 24-hour lab, X-ray, and blood services. They are able to provide fetal monitoring. Press can do all of that. They have special nursery. And here's level 3. Everything that level 1 and level 2 can do. They have 24-hour consultation assistant for hospital within the region. Something comes out, let's say, very sick baby, and the person over there at press doesn't know what to do. They can pick up the phone and call somebody at UNM and ask them questions. Methods and personnel to transport from level 1 and to level 3. Yeah, they have somebody over there that is capable, a nurse and a respiratory therapist. Have to accompany the baby to UNM. They have to come over to UNM. If they're flying from here to New York, they have to have a respiratory therapist that knows about taking care of babies, a nurse, a doctor. All of them will be in that team to fly the baby to wherever the baby is going to have that special procedure done. Coordinate educational program for the region. Yeah, every once in a while, press can go to UNM and get education about babies, especially if there's something new. Provide data analysis for the region. Conditions that necessitate transport. Obstetric problems. Premature rupture of the amniotic membrane. Yeah, you can be transported, but because basically, anytime the membrane ruptures, that's an onset of labor there. Okay, the baby gets in distress. Surgical problems. Okay, cyanotic heart disease. Transposition of the blood vessel, arterial septal defect, they gotta have some kind of surgery, PDA, okay? Then the baby has to be transported to a hospital where that can be done. Medical problems, okay, they have drug overdose, persistent pulmonary hypertension of the newborn, severe maternal infection, that kind of stuff. And how do you transport the baby to that other hospital? Well, we have maternal transport before the baby is born. If you can identify that this is a baby that when it comes out will be very, very sick, it is safer to transport the mother to that hospital and have the mother deliver the baby there, okay, where the services are going to be right there, as opposed to the mother having the baby at one hospital and then, have to be transported to the hospital where the baby can receive care. So it is safer, it was convenient to transport the mother than transporting the baby. Okay? And then we have ground transport. Ground transport, you're using the emergency medical services. Okay? And when the distance is less than 100 miles, okay, if they're going from Press to UNM, well, hopefully you don't have to fly them, you know, you're gonna have to drive them over there, okay? If they're going from like UNM to, I'm just using an example, they're going from Grimes to UNM, well, if it's very serious, you can use a helicopter to fly them over there. And that's one thing with a helicopter, you can land in front of the hospital and then the patient can be wheeled into the hospital. And but now if you're going from like UNM to somewhere in New York, you're not going to use a helicopter, you're going to use fixed wing aircraft. So it depends on the distance that you're going and what is actually wrong with the baby. So for ground transportation, the distance has to be less than 100 miles. The advantage there is that the vehicle can easily be stopped if emergency arises. Like you're going over, there is some kind of emergency, you can park the car and take care of the baby and then continue your journey. And, if the baby was in an aircraft, especially fixed wing aircraft, and something happens where you're not going to all of a sudden land the aircraft, you know, you have to go to an airport to do that. Okay? So that's good about that. This method can be slow due to traffic jam. The caveat about that is that if you have traffic jam or there's a wreck somewhere on the way, that slows the whole process down. That slows down the whole process. Air transport, we can use a helicopter. Okay, the distance is between 100 to 250 miles. Okay? Used when obstacles make land transport impossible. And that is true. For some reason, we cannot go by land transport. We can use helicopter. Can land almost anywhere. That's one thing good about helicopter. Like at Press, you know, I've seen them bring in babies. You know, it lands right there in front of the hospital, and then the patient is just wheeled into the hospital. It is fast, but noise level is too high with helicopter. And then we have fixed wing aircraft. This is when the baby will be traveling, you know, greater than 250 miles. Okay. High speed, well, the baby will get there on time, quicker. But now weather condition can be a problem too. Okay, if it is snowing or any other kind of problem with fixed wing aircraft, that can slow the process down. And another thing is the fixed wing aircraft would have to land at an airport. Well, how far is the hospital from the airport? That's another thing. So you land there and then they use ground transportation to transport the baby to the hospital. So that kind of delays things a little bit too, but the fixed wing aircraft will get there quicker, okay? And then the next thing is that there's a lack of space. Okay, if you have flown before, you can tell that the fixed wing aircraft doesn't have a whole lot of space there, you know, to do things. Any questions about that? Altitude problems during transportation. Yeah. When the baby is being flown from one hospital to another, a lot of things can go wrong. We have to be prepared to do that. Okay, you have to, for instance, you have to take everything that you need in case something happens. One thing that we have to have in mind is the barometric pressure. Okay, barometric pressure decreases as altitude increases. The higher that you go up, okay, the lower the barometric pressure. Okay. that can make a lot of patients hypoxemic. Okay, that can make a lot of patients hypoxemic. So we want to make sure that we have oxygen tank in abundance to maintain the patient's oxygenation. And this is what you're looking at here. If you work out this formula, this is called the alveolar equation. If you work out this formula, to get the partial pressure of oxygen in the alveolus, you get approximately 100 here. So that's normal parametric pressure here, 760. So now, we know that oxygen crosses over from the lungs into the blood through the process of diffusion. And one of the things that affects the rate of diffusion is concentration gradient. So here's the blood here. Let's say that a patient has 60 here in their blood. The diffusion gradient here is 40, so oxygen will be moving over normally into the blood. So assuming now that you're flying way up and the barometric pressure goes down, okay, let's say to 640. Well, when you do that math, it's not going to be 100, it's going to be less than 100. Let's call it 80. The gradient there now is 20. So not a whole lot of oxygen will be crossing over into the blood. So patients can get hypoxic as you fly up. Now, inside the airplane, for instance, when you get inside the airplane, the chamber is pressurized to 760. The pressure inside the airplane is pressurized to 760. So that's how come once you go in there, they will tell you that if the cabin pressure drops, there will be non-rebreather mask coming down, okay, and then you're going to put it on first before you try to help somebody else. I guess you all remember that, right? Yeah, yeah. So, yeah, put it on before you try helping somebody else. So that can happen. That pressure, if you lose that pressure inside the cabin, everybody in there is going to be hypoxic because we're like thousands of feet away from it. Okay? So that's something that we have to keep in mind. Carry plenty of oxygen. In case that happens, we can increase the oxygen pressure by letting them wear at least a non-rebreather device. Another thing is gas in a closed chamber expands as altitude increases. Like if you have pneumothorax, okay, pneumothorax now, that's gas there, a bunch of air inside the thorax. If we're flying up, it will expand because Boyle's law states that at a constant temperature, as volume decreases, pressure increases. Well, as volume increases, pressure decreases. Okay? So with a decrease in pressure as you're flying up, the volume increases. So the pneumothorax grows bigger. Okay? So we have to be prepared to make sure we have chest tube to evacuate the air that is going to build up some more. Okay, things like you make special preparation based on the type of patient that you have. Forces of acceleration and deceleration of the aircraft, yes. It affects blood flow when the plane goes like that, or maybe it goes like that. Now, if somebody has hypertension in the ICU, would you put their head down or would you put their leg down? Which one would you have? You put them down this way, right? Yeah. Yeah, put them in one blood flow to go that way. Kind of like the same thing here. When the plane goes like that, or maybe goes like that, that affects blood flow. Okay? Any questions about that? Personnel and equipment. Highly trained personnel, including respiratory therapists, nurses, paramedics, and emergency medical technicians. All of them are involved, and at least you have one of every member of the healthcare in that transport, the transport team. Okay. Almost every type of equipment available in the NICU is needed. Yeah. Like now, let's say that you forgot to take a nasal cannula, or you only took one, and then you're all the way up there, and something goes wrong with that one you got. Well, you're not going to tell the pilot, please, can you land? I need to go and get some more cannulas. You can, you can tell them that. So you have to carry a lot of them, okay? Enough. And then as you go down the line, you're going to figure out, like, even the tank, okay? You have to be able to calculate duration of flow. If you are going with 2 E-tanks, okay, and the patient is going to wear 1 or 2 liter nasal cannula, how long will it last? Okay, you have to take enough oxygen that will last you for 5 hours if the flight is going to be for 5 hours. Okay, so a respiratory therapist has to be able to calculate that and know that the oxygen that they're taking with them should be enough. Okay? So here's duration of flow here. So if you're a respiratory therapist, you're going on that transport. The start of the cylinder that you're going to take depends on how long the flight will be and how many liters per minute the patient is wearing. Okay, so now let's kind of review. This is like a semester 1 here. First of all, let's go with the tank factors. The tank factor for this cylinder is 0.16. The tank factor for this cylinder. And then for each cylinder is 0.28. And for G cylinder, it is 2.41. And then for each cylinder, it is 3.14. I remember that one with pi, the value of pi. So you got to be able to remember all of these, okay? And then let me see what I got here. All right, so now as far as calculating the duration of flow, you're calculating the duration of flow. There's a formula for that, okay? Let's say that a full tank of oxygen will have 2200 psi. A full tank, whether it's each cylinder or each cylinder or this cylinder, that's the amount of pressure there in the tank, 2200 psi. Okay. But now let's say that I'm going with a full tank of each cylinder. Okay. And my patient is going to wear 2 liters per minute. There's a cannula. How long would that last in hours? Okay, so you remember the formula that says duration of flow equals tank factor times PSI, the amount of pressure in the tank, divided by liter flow. That's the formula you should remember. So now, let's say that my e-cylinder is full, it has 2200 psi. So I put my tank factor here, 2.8 times 2200, like that. My patient's gonna wear 2 liter nasal cannula. So divided by liter flow, which is 2. I don't have my calculator with me. Can somebody multiply 0.28 by 2200 and divide it by 2?
It's about 308. 308.
308? Okay. So now, the answer comes out in minutes. You gotta remember that. The answer comes out in minutes. But the MBLC test, they always want you to go that extra step of converting it to hours. So you're gonna divide 308 by 60, divided by 60.
5.13.
5.13 ounce. So it's gonna last at 5.13 hours. So you have to be able to tell whether the distance, excuse me, the time that you will get there will be less than 5 hours. Then that e-cylinder will be enough if the baby is wearing at 2 liters per minute. And the test, sometimes they may go like 5 hours and so minutes. Okay, so this is not 30 minutes. What you gotta do is you multiply that 0.13 by 60.
5 hours, 8 minutes.
Huh?
5 hours, 8 minutes.
Yeah, 5 hours and 8 minutes, yeah. So if they write it out that way, that's what you gotta do. Just multiply the decimal by 60 to convert it to minutes. Let's do one more because you will have this on your final exam. Okay, now let's say that the top is gonna take an e-cylinder and the patient is gonna wear 3 liter nasal cannula. So I'll go duration of flow, time factor. You know, this is what Kevin is going to teach you, okay? Well, these days they let you use the calculator anyway, so it won't make that much difference. Long time ago, they won't let you use your calculator, okay? But then the way I taught students then was to just use 3. Like if I'm gonna do a cylinder is 3.14, I'll just use 3. Once you work it out, you're gonna see an answer that is very close. But now that they let you use calculator, if you want to, you can use 3.14, okay? And then let's say that the e-cylinder is not completely full right now. It's got only 2,000 psi, okay? And then the baby is gonna wear 3 liter nasal cannula. Okay, there we go ahead and multiply 3.14 by 2,000. And divide it by 3.
I got 2,093.3.
How much?
2,000. I think my calculator broke.
Yeah.
No, I got the same thing.
Did you? Okay.
Actually, what did you get?
I got the same thing as you got.
2,000?
Yeah, 2,093.3.
2,093.2?
Point three.
It's okay.
23?
93.3.
Okay. Let's call it 2,093 minutes. And then you're gonna divide that by 60 to convert it to hours. be over 24 hours.
About 35.
35, okay, yeah, 35 hours. Well, you have to be going to Nigeria to stay in the airplane that long. But that's the way you do it. Can everybody do this on the exam? I'm gonna give you one or two questions where you have to calculate duration of flow. You have to remember this stuff. Now that's why I told you to start reading your review book from chapter 1 all the way. And they ask you everything that you've learned from day one. Special needs. Special preparation depends on the type of patient that you have. But one thing that we need to do is to keep the baby warm while we're transporting the baby. Okay. Usually, most of them get transported with an incubator. Incubator is what they use for transport because it provides a controlled temperature environment for the baby. Okay? So provide adequate warmth for the neonate in order to prevent hypothermia and cold stress. Remember, if babies go into cold stress, they will start using that brown fat that they made in utero for metabolism. And we don't like for them to use it up before they get to the point where they will start generating body heat like we do. Okay, so we're always trying to prevent them from getting cold for them to conserve that brown fat. Okay? To conserve body heat, do the following. Use incubators for transport. Like I said, that's what they mainly use. Minimize handling the baby and opening the incubator door. Because anytime you open it up, the baby will lose body heat to cold air. Okay, that's convection there. Use cap over the baby's head. Use a warm blanket to cover the baby. Okay? Now, you're going to transport a baby that has diaphragmatic hernia. Transport patient with head elevated and the affected side of the thorax down. Elevated that way, and then the affected side down. That's the way they're going to fly. Insert a nasogastric tube to evacuate any air that enters the stomach. Yeah, you put empty tube down into their stomach. Intubate to ventilate rather than ventilate with bag and mask. So we don't like to do that. You rather just intubate them because if you're bagging them, air can still enter their stomach and push up and further compresses the lungs. So they're better off you intubating them and bagging them. If you're going to transport somebody or a baby that has tracheal or esophageal fistula, a little hole between their trachea and their esophagus, transport with head elevated, place a feeding tube in the esophagus to evacuate to build up secretions. Avoid mechanical ventilation if possible to avoid distension of the gastrointestinal tract. Now, if you're transporting a patient with spina bifida, where the spine didn't quite close up at birth, avoid contamination of the defective area. So you're more like you're going to have to use a septic technique in handling the baby. Make sure you have your gloves and clean your hands really well. Exercise care to not rupture the covering membrane if it is present. Maybe you still have membrane, but it didn't quite fuse very well, cover up. Transport in a supine position. Now, I don't know why that is so. I guess it's more protective, because then the spine will be back that way without you messing with it a lot. Okay, maybe that's why they would rather be supine.
So wouldn't you have to worry about increased friction?
Huh?
Anything in the area?
Say it again?
Wouldn't the baby is laying supine, like on their back, don't you have to worry about friction of them moving in transport?
Can you take that off? I'm sorry.
If the baby is laying supine and they have spina bifida, which is exposure to the spine, don't you have to worry about, them friction causing
Yeah,
damage to
yeah.
that area?
Yeah, that is
Wouldn't you
true,
do
that is
better to
true.
lay them in a prone?
Yeah, that's true, but I'm assuming that they will have something that is sterile, have probably like a sterile field,
Mhm.
to put the baby down and, something like that. Yeah, that's a good question, but I think that would be a good way to protect, infection going in there. Okay, making sure that whatever the baby is gonna lie on is sterile. Okay? All right, how about if you are transporting a baby that has sciatic heart disease? Okay? Treated with prostaglandin E. Now, sciatic heart disease, the baby doesn't pink up, okay? And one of the things that may cause that is PDA, patent ductus arteriosus, okay? And we want it to stay open, okay? We want the PDA to stay open so that the baby can oxygenate better. But if it closes, no, wait a minute. Yeah, if it closes, then we're in trouble. Okay, so that's why we're going to do prostaglandin E. It will keep the ductus open. Okay? It keeps the ductus open. Omphalocele. That's herniation of the intestines directly into the base of the umbilical cord. And then we have, I can't say that word, gastroparesis. The intestine herniates through the abdominal wall. That's what that means. In either one of them, you want to make sure you maintain a septic environment. Prevent pulmonary aspiration of stomach contents. Prevent excessive loss of heat through evaporation. Provide respiratory support. Any questions about neonatal transport? Alrighty then, that's it. So now our exam, like I said, you will have 40 questions. And the questions